Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another clinical series episode. I am your host, Jana Emil, and joining me is Dr. Sally Miller. Dr. Miller, how are you today?
I'm very well, thank you. And you?
Very good, thank you. Now, I know you're my best esteemed guest that I have on the podcast, but for whoever hasn't heard you or seen you yet, can you just give us a little introduction of who you are, your background, and where you practice?
So my name is Sally Miller. I've been a nurse practitioner for 30 years. This is my anniversary. 1993 was my first NP certification. I know, I can't believe it. So I've been around the block a little bit. I hold several certifications in acute care, primary care, family, adult gyro, et cetera, and psych mental health. So in 30 years, my practice experience really has run the entire gamut. And for the last 5 years, it has included 1 day a week in a mental health practice. So that's what I bring here today for both the primary care NPs and the mental health NPs. And I teach, I've been a professor of nursing for 27 years, have taught nurse practitioner students regularly ever since 1995, and mostly pharmacology, physiology, the occasional clinical course. And I maintain a clinical practice, and I am a fellow of the American Association of Nurse Practitioners.
Very nice. And I'm going to put in a shameless plug. There are very few people in the world that teach pharmacology as well as you. We've had a lot of pharm episodes, and I got to tell you, I walk off of these podcasts and I'm like, just put me in a pharmacy anywhere. I pretty much know exactly what I'm doing.
Thank you. I appreciate that.
You're great at that. So we are going to talk a little bit psych, right? We're going to talk about personality disorders. So I want to set the groundwork, right? Like, what are they? Is a personality disorder when I don't want to talk to my husband for a whole day because I'm just super annoyed with him? Like, is that what it is? What's a personality disorder? Let's start there.
No, that's a normal compensatory response to marriage. That's a protective mechanism to preserve the marriage. So personality disorders, by definition, everything has a definition. They are diagnoses, and they have diagnostic criteria, just like anything else, just like hypertension or asthma or diabetes. There are criteria. And as you might imagine, most of the criteria do include various features of personality. But at the end of the road, it is also a requirement of diagnosis that they interfere with social or occupational function in some way. Virtually every psychiatric diagnosis needs to have that qualifier to be a diagnosis because, everybody has personality quirks, and everybody has an aspect of personality or a trait that others might not enjoy or want to be around. But it becomes a disorder when you have a collection of traits that really interfere with your world in some way, that they are causing a problem in your personal life or a problem in your work life, like you lose a relationship over it, or you have perpetual relationship problems because of your personality characteristics, or some people lose their jobs because their personality characteristics make it impossible for them to function in that interpersonal environment. So that's really the key. There's traits, we all have them. One of the assignments I use when I teach this is I have my students at the university identify public figures, like celebrities or someone in the public that they think has these traits. And but we don't make diagnoses, because you can't diagnose a person without actually interviewing them. But we can see all sorts of people that have traits of personality disorders. Making the diagnosis really does require that there's some significant impairment of function.
Yeah, that's a really good point. So it has to interfere with life, essentially, before we say that that's truly a disorder. So right. What are some of the common I think about personality disorders, and I think about probably not even diagnosable things. I think I'm thinking about these traits, right? When there's a quirky person, I'm thinking, they're antisocial, but I know I'm slapping a diagnosis on that person just based off of, what I'm seeing. But what are the personality disorders that we encounter often?
So, the incidence of personality disorders in the population is estimated to be between 4 6%. So we do
Oh, wow.
encounter them. I mean, if you are in a group with 20 people, statistically, one of them has a personality disorder. So if you've ever been like in a class of 50 people, statistically, 2 of them do. So they're definitely not rare.
Yeah.
So there are 10 commonly recognized or diagnosable personality disorders. And even though DSM-5, so DSM, the Diagnostic and Statistical Manual of Psychiatric Disorders, the DSM is essentially the Bible of psychiatric diagnoses. And it gets restructured, reorganized every, 5 to 10 years. And most recently, they've modernized the terminology a little bit. So we don't properly still call them cluster A, B, and C, but everybody who works with personality disorders will tell you that they come in 3 clusters, what we refer to as cluster A, cluster B, cluster C, mad, bad, and sad. Or I guess if I want to rhyme, I'd say mad, bad, and sad. And I mean, some of that terminology, some people think it's offensive. I mean, it certainly isn't intended that way. The mad is used in the classic sense of like the mad scientist, of sort of that we associate with insanity or, like that. So
Okay.
maybe it's not the most contemporary term, but it's still one that most clinicians will recognize. So the cluster A's are the mad disorders, the cluster B's are the bad, and cluster C is sad. Cluster B is actually the one that most people are familiar with. There's 4 personalities in that cluster: narcissistic personality disorder, histrionic personality disorder, borderline personality disorder, and antisocial personality disorder. So they're all the ones that are bad, like bad boy, like I always want to license that Michael Jackson song and play it whenever we talk about the bad personality disorders. But they're the ones, antisocial personality disorder is what is commonly referred to as your psychopath. When we're talking about like the Ted Bundys of the world, the Ted Bundys, or who was the guy that ate they just did a Netflix show about it. The one that used to eat people.
Are you talking about like Hannibal Lecter, those movies that we saw?
Well, him too.
Yeah.
There's another one, but the Dahmer, Jeffrey Dahmer.
Oh, Jeffrey Dahmer. Yes.
You remember the case of Jeffrey Dahmer? Yeah. So like that would be, now not all antisocial personalities are murderers or cannibals. I mean, those people typically are antisocial, but there's lots of people that have an antisocial personality disorder and they get into trouble. They lie. I mean, they are essentially without conscience for the most part. And the thing is that they will, and I'm talking antisocial personality disorders here. They generally, they need gratification. They want what they want, and they are pretty much without conscience in getting it. So if it requires lying or stealing or breaking the law or whatever, they'll do that. But it doesn't, like I said, they're not all murderers and cannibalistic, but those people, those types of Ted Bundy people do have antisocial personality disorder. It really is primarily the feature really is, without what we think of as a conscience or empathy, their primary driver is to get what they want at any given time. And they tend to be very charismatic, like Ted Bundy. Everybody talks about how handsome he was and how people were drawn to him, that kind of thing. So that charisma often helps people get what they want. And sometimes it's just about manipulating an environment. So those are antisocial. And there are people with antisocial characteristics or antisocial features, but they don't necessarily constitute a personality disorder because there are very specific criteria. I'm just throwing out the most common ones. But if you look at the DSM, there's a list of criteria that we look for. The borderline personality disorder, that's the one that is very often confused with bipolar. Borderlines tend to be extremes. They are the all or nothing. They are characterized by this splitting that we so commonly use. When we split people or split circumstances, we refer to all or nothing. Like, this is the person who you're talking to them, and we see this in the office all the time. When they first come to you as a provider are great, you're amazing, you're awesome. They're so glad they found you because the last person they saw was horrible and didn't know anything. And You see the extremes that we're talking about here.
Yes.
This tends to be part of their personal lives as well. The relationships tend to be really turbulent because this is somebody who will, break up or toss out a significant other, throw all their stuff literally out the window, out on the street one day, and then, 5 hours later be driving around trying to find them because they want them back. That's what we're talking about with splitting. And it just creates for a very turbulent life. So there's usually a lot of what we would call drama. Lives are characterized by high drama, just very difficult to be around. Then the narcissistic and histrionic. The narcissist, we most of us see that term used conventionally. The narcissist really is very, self-involved. They think they should be the center of the universe and everything should be about them. And there are lots of people that have narcissistic traits that are very successful. In fact, many of your most successful people have some narcissistic traits, but it doesn't rise to the level of a narcissistic personality disorder. Now, it becomes a disorder when those traits are so extreme that it does interfere with work or school or love life, et cetera. But they're very self-centered. Everything's about them. The histrionics, they're the ones that need to be the center of attention, like all about me, like, look at me, how smart am I? How good do I look? How awesome am I? If somebody else is the center of attention, they have a hard time with that. And again, lots of people have that trait, but when they meet certain criteria and it interferes with day-to-day living, then it becomes a disorder. So those are the ones that most people are more familiar with your four bad, your bad cluster. And then the sad cluster is what are known as obsessive compulsive personality disorder, which is not the same as obsessive compulsive disorder. You'd think somebody could have named them differently, but
no, seriously.
I know. But there is an obsessive compulsive personality disorder, avoidant personality disorder, and dependent personality disorder. And they are sad, dependent and avoidant. Those are people that typically go to extremes to avoid any kind of conflict, anything. The dependent personality is the one that really just has to have somebody else in their lives managing things. And the cluster A, I think I glossed over those. Cluster A, the MAD personality disorders, there are 3 in that cluster. They are known as paranoid personality disorder, schizotypal personality disorder, and schizoid personality disorder. And those are people that they typically do have some qualities that are not psychoses, because characteristic of the cluster A's is the patient is not psychotic in the traditional way. They're not out of touch with reality, but they often do have a little bit of delusional thinking. The cluster A's, like typically, a lot of us grew up like there was that old person on the street, the crazy old lady that lived alone and everybody just avoided her. And there was probably a cluster A thing going on there. So they, the paranoid personality disorders, they do have a sense of paranoia. It just doesn't rise to the level of a psychosis. The schizoid and schizotypal, they almost have a little bit of magical thinking. They tend to be very not connected to other people, very much loners, and don't even really miss being, having relationships with others. But they all function independently, not like a patient with schizophrenia who really is disconnected from reality when they're not controlled. So those are our clusters, A, B, and C. The MAD are your schizotypal, schizoaffective, and paranoid. Cluster B, there's 4, are borderlines, antisocials, histrionics, and narcissistics. And then cluster C are also 3 disorders, obsessive compulsive personality disorder, avoidant personality disorder, and dependent personality disorder. And they make up our 10.
Yes. And thank you for defining that, because one of the things that I think about is, and I do this too, guilty, we throw out those words. We say like, that person's a narcissist, that person's a this, that person's that, based off of, quite honestly, definitions we kind of make up in our mind, what we see and hear, on TV and what we've learned in that way. But to hear it framed out and like define truly in what it is does help to piece out, what's true. What are we really seeing as traits? So, my next question then, of course, as I'm thinking about these clusters is, can a person have more than one of these personality disorders. And then I imagine, gosh, that gets tricky.
They very often do.
Okay.
Yeah. It's very common that people in one cluster will have traits of another cluster. Yeah, absolutely.
Wow. And so then what's treatment look like? And one thing I've learned from you is that it's never just medications alone. It's never just drugs alone, especially, in something like when we talk about personality disorders. And I'm guessing that every single one's got a little bit of a different treatment path. So how do MPs handle that?
They do. I mean, it is really a challenge to treat personality disorders, because one of the characteristics of personality disorders that you don't usually see in mental health disorders is the patient typically does not acknowledge that anything is wrong. People that are bipolar or depressed or have anxiety disorder, they know something's wrong. They come to us wanting treatment. They acknowledge they have a diagnosis. Even most people with psychotic disorders like schizophrenia, they typically also recognize that they have a problem and they want help. But the personality disorders, one of the features of personality disorders is that they typically don't recognize they actually have a problem. So you can imagine how hard it is to treat people that don't acknowledge they have a problem. The other thing about the personality disorders is that there isn't really a clear biological dysfunction like there is in others. We've talked about this in other podcasts where in many psychiatric disorders, there is a very clear imbalance of neurotransmitters, and that while medication isn't usually the only thing, there is clearly a role for medication in trying to normalize some neurotransmitters. This is not the case with personality disorders. The neurobiology is really in its infancy in terms of investigation. For the most part, personality disorders are still believed to be primarily psychoanalytic and environmental. In other words, that they are a consequence of upbringing and environment in childhood. There is some suggestion that there might be some biologic predisposition to certain things, like antisocial personality disorder. There does appear to be a familial, like parents that have antisocial personality, like the kids have a greater risk of developing it. In kids, we call it conduct disorder until they're 18, and then many of them do go on to become antisocial. But the question is there a genetic link, or is it the chaotic environment of the antisocial parent? So it's really unclear. There's a couple of, like I said, a couple of studies that support specific personality disorders may have a biologic link, but it's not nearly as clear as it is with many other psychiatric disorders. And so the treatment therapy has always been the mainstay of treatment for a personality disorder. They need to see not only a therapist, but a therapist who is particularly skilled in managing that disorder, which means you have to get them to acknowledge they have a personality disorder in the first place. I mean, it's hard. With the borderlines, I find in my practice, getting people to acknowledge they have borderline personality disorder is a real challenge, because somebody has often already told them they're bipolar. And as one of my borderline patients told me, it's cool to be bipolar, but not cool to be borderline. She's a teenager, and it's cool to be bipolar, not cool to be borderline, I guess, on TikTok.
That's interesting.
So during one of our visits, and it was a Zoom visit like this, in the chat box, one by one, every criterion for borderline personality, there are 11 of them, every one of them, I put in the chat box one item and say, is this you? And she'd say, oh my gosh, yes, that's exactly me. Last week, blah, blah, blah. I'd say, okay, take the next one. Do you identify with this? She'd say, yes, remember when last month we were talking and I told you every criterion? She said, yes, 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 that's me. And I said, you have a borderline personality disorder. Medicine will not help you. You need a therapist. And that's when she told me it just wasn't cool to be borderline.
Wow.
So, and then once somebody does acknowledge that they're borderline, therapy for it is really a challenge. There's a very particular type of therapeutic approach called dialectical behavioral therapy, and it needs to be administered by a therapist who has been trained in it. And it's so really good treatment for these personality disorders. It is a challenge because the therapist has to be skilled, the patient has to acknowledge it, and then they need to want treatment. Many times, like the cluster A people, they don't really like the schizoids and schizotypals. They don't care that they're aloof, and distant. They're happy. They're not, well, happy is probably not really a word that applies to them, but they're content in their existence and aren't really necessarily interested in therapy.
Wow.
So
that is tricky stuff. So I imagine
it can totally be done. Yeah, but it's a challenge.
Yeah. And I imagine the first thing, I'm thinking about the difficulty in just accepting that, right? As a patient, I bet that they hear it from their friends and their families of people that are closest around them that are saying, hey, I think you got something going on, but that's a whole different thing than accepting it, on your own. So I'm thinking about NPs like in primary care and family practice, right? That might, have a patient that comes through, or they come across a patient that they think has some type of personality disorder. At what point for that primary care NP, that family care NP, are they referring out? Do they say like, okay, this is interfering with the medical stuff, like physical things I'm trying to do. We need to refer out. I'm not the right person, or we need to do a little bit more than what we're doing now. How do they make that distinction?
Usually, the way that this comes to present in primary care is that people will come in with symptoms that are depressive and anxiety types of symptoms, because these personality disorders can precipitate that. I mean, like someone who truly has a narcissistic personality disorder, they're still human. They still want relationships. They still want, to be successful in their work environment, and they usually aren't. So they can get depressed, and then they come in looking for treatment for depression. Or someone that is borderline, they too, I mean, they want to have successful relationships and they want to interact in their world, and they very often will have anxiety because of this, up and down, like all or nothing approach that they have to the world. So usually what happens is they come in with complaints that sound like more typical, commonly encountered mental health complaints. And a lot of times the primary care provider won't pick up on the personality disorder because they're not looking for it. If in primary care, if somebody comes in complaining of anxiety, we do an anxiety assessment, and if they have it, we treat them, and same thing with depression. And so we don't really appreciate the personality disorder piece. But and you actually can, someone who's got a depressive or anxiety symptom, treatment can make that symptom better, but it doesn't take care of the underlying problem. So often what you'll see in actual practice is treatment for the condition doesn't really help. It might help a little, but you have the person on an antidepressant and you titrate it up, and they're still having problems at work or home or whatever.
That makes
and
sense.
then if you can just start to think about, like, asking the questions in your assessment about relationships and about work, and how is that going, and you start to hear things about like, oh, everybody at work is stupid, or everybody's a jerk, or like that kind of thing. And then you start to think, oh, there might be a personality disorder here. And there are personality disorder, there's screening tools for it. So in a more comprehensive primary care practice, especially with a first visit, a lot of tools are filled out, like a sleep index, and sometimes a mental status exam for all new patients, and a diet history. And you can throw a personality screener in there. Or if you don't do it for all new patients, when you see those people that come in that are complaining of the more typical symptoms, but they're still having trouble, they appear to be having relationship issues, then maybe have them complete a personality screening tool. Not that primary care can treat it, because they really can't. They don't have the skill set to do it. They need to refer them to a therapist, really, a therapist more so than a psych prescriber. But sometimes if you have them do the screening tool and they can see that they score like that suggestive personality disorder, sometimes that's just a more objective, an impetus, like, well, this score does suggest that you might have this disorder. So, why don't you consider seeing a therapist? And if they're really resistant to a therapist, because, a lot of people are in the beginning, then send them to a psych provider. And then, Rome wasn't built in a day. Sometimes the psychiatric provider can really get them connected to a therapist.
Yeah. You said something earlier that I'm thinking about. You talked about for personality disorders versus some of the other like mental health disorders that we podcasted about, like depression, right? There's a biological factor in that way. But you spoke about like external factors and even just familial, maybe social things when we talk about personality disorders. And so my brain is going to, I wonder, are we encountering more personality disorders? Maybe encountering is not the right word, maybe diagnosing more personality disorders since the pandemic. Like, what has that type of experience as far as external factors, created for? I'm thinking about folks that already maybe had an underlying mental health disorder and was exacerbated in different ways. Has that had any implication? Like, do you think, even in your own opinion, in your own practice, have you seen more of that rise to the top since the pandemic?
That's a good point. I mean, I hadn't thought about it specific to personality disorders, but it's very likely. I mean, just for that year that people were around their family all the time,
That's a good point.
Having to be with people, even if it was a good environment, when you're around people more, they can notice things. I mean, we do know that the majority of personality disorders, there definitely does seem to be some level, a strong level of what was in the upbringing, how their childhood evolved. But by the time we actually see the patient symptomatically, they're out of that environment and trying to interact in their own adult world. So I don't, with the kids, I mean, the kids are a whole different circumstance. We don't even diagnose a personality disorder until you're 18. When you're under 18, there are other anomalies that can occur. Like I think we talked about some of these in the alphabet soup of children and behavioral disorders. Yes, that some of them have a higher incidence of personality disorders in adulthood. There's all sorts of little qualifiers, like the DSM, sort of the blanket approach is we don't really call it a personality disorder until you're over 18, but there's always the qualifier, the unusual circumstance. So I guess I shouldn't say we don't diagnose them till we're 18. Sometimes we do, but typically a personality disorder just becomes more evident in adults.
So more of the exception.
But yeah, COVID really, I mean, certainly COVID just had a huge impact on depression and anxiety and PTSD, even the things that people saw early on in the healthcare environment. Just, remember back in the very beginning, like if you were in the hospital dying, your family couldn't even be in the room. And it was the staff attending to the dying patient who was all alone. And that really did produce some truly, significant PTSD sorts of events in people and depressive symptoms, et cetera.
Yeah, this has been great information. Is there anything that we haven't covered that you would like to share with the NPs that are listening right now about personality disorders, whether they're primary care, whether they're practicing in psych, just things that, you want to drop some gems for them?
I'll tell you what, these are really big, exhaustive, and they're best discussed in case study presentation. Because, it's one thing to list a set of 11 symptoms and then, yes, we memorize them, boom, boom, boom. But then in day-to-day clinical practice, just really don't have the time or haven't had the opportunity to synthesize. So one of the best ways to go over personality disorders is to take a case, how they present in the office. Like people with paranoid personality disorder don't come in and say, I made this appointment because I'm paranoid and I'm afraid that this paranoia is interfering with my social or occupational function. Like we have to look for little gems in their presentation. So of course, now I will offer a shameless plug because here at FHEA, we're doing actually a 3-set series. It's going to be a total of 12 hours, 4 hours on each personality cluster. So and that's one of the things we'll do is really drill into these criteria, but how the patient presents, how we become suspicious for a personality disorder, and then what to do about it. One thing though, I didn't say when we were talking about treatment, and I probably should, and maybe we'll leave your audience with this. Even though the primary treatment modality for a personality disorder is therapy, that doesn't mean that we can't treat the symptoms sometimes with pharmacotherapy. Like I said, some people, their disorder really does produce a significant depression or anxiety or anger management issues, uncontrollable or disproportionate anger and irritability. And we don't just say, well, we can't help you because you need a therapist. If the patient's not ready for that, they're just not ready to hear it. Sometimes you have to reintroduce it every time you see the patient. But in the interim, we still can use medications to try to improve those symptoms that they have and just improve their quality of life a little bit. So if you see somebody with those depressive anxiety or anger symptoms, just because in a perfect world we want them to see a therapist for the personality disorder, if they won't, we can manage their symptoms with pharmacotherapy while we persistently try to encourage them to see a therapist.
That's good. That's good, helpful information. Dr. Miller, thank you again so much for your time, for your knowledge, for all your energy. As always, this was a great episode conversation.
Always a pleasure. Thank you for having me.
Thank you. And thank you all for tuning in and listening. We hope you enjoyed today's episode. And if you'd like any more information about what we spoke about today, check out our course offerings on FHEA.com. We hope you enjoyed, and we'll see you next time. Goodbye for now.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.